Chapter 1. Classification of Psychiatric Disorders. Any discussion of the classification of psychiatric disorders should begin with the frank admission that the definitive classification of disease must be based on etiology. Until we know the cause of the various mental illnesses, we must adopt a pragmatic approach to classification that will best enable us to care for our patients, to communicate with other health professionals, and to carry out high-quality research. In physical medicine, syndromes existed long before the etiology of these illnesses were known. Some of these syndromes have subsequently been shown to be true disease entities because they have one essential cause. Thus, smallpox and measles were carefully described and differentiated by the Arabian physician Rhazes in the 10th century AD. With each new step in the progress of medicine, such as auscultation, microscopy, immunology, electrophysiology, etc., some syndromes have been found to be true disease entities, while others have been split into more discrete entities and others jettisoned. For example, diabetes mellitus has been shown to be a syndrome that can have several different etiologies. On that basis, the modern approach to classification has been to establish syndromes in order to facilitate research and to assist us in extending our knowledge of them so that ultimately specific diseases can be identified. We must not forget that syndromes may or may not be true disease entities, and some will argue that the multifactorial etiology of psychiatric disorder related to both constitutional and environmental vulnerability, as well as to precipitants, may make the goal of identifying psychiatric syndromes as discrete diseases an elusive ideal. Syndromes and diseases. A syndrome is a constellation of symptoms that are unique as a group. It may, of course, contain some symptoms that occur in other syndromes also, but it is the particular combination of symptoms that makes the syndrome specific. In psychiatry, as in other branches of medicine, many syndromes began as one specific and striking symptom. In the 19th century, stupor, furore, and hallucinosis were syndromes based on one prominent symptom. Later, the recognition that certain other signs and symptoms co-occurred simultaneously led to the establishment of true syndromes. Korsakoff's syndrome illustrates the progression from symptom to syndrome to disease. Initially, confabulation and impressibility among alcoholics were recognized by Korsakoff as significant symptoms. Later, the presence of disorientation for time and place, euphoria, difficulty in registration, confabulation, and tramline thinking were identified as key features of this syndrome. Finally, the discovery that in the alcoholic amnestic syndrome there was always severe damage to the mammillary bodies confirmed that Korsakoff's psychosis syndrome is a true disease with a neuropathological basis. Sometimes the symptoms of the syndrome seem to have a meaningful coherence. For example, in mania, the cheerfulness, the overactivity, the pressure of speech, and the flight of ideas can all be understood as arising from the elevated mood. The fact that we can empathize with and understand our patient's symptoms has led to the distinction between those symptoms that are primary and which are said to be the immediate result of the disease process, and secondary symptoms, which are a psychological elaboration of, or reaction to, primary symptoms. The term is also used to describe symptoms that cannot be derived from any other psychological event. Early distinctions. The first major classification of mental illness was based on the distinction between disorders arising from disease of the brain and those with no such obvious basis, i.e., organic versus functional states. These terms are still used, but as knowledge of the neurobiological processes associated with psychiatric disorders has increased, their original meaning has been lost. Schizophrenia and manic depression are typical examples of functional disorders, but the increasing evidence of the role of genetics and of neuropathological abnormalities shows that there is at least some organic basis for these disorders. Indeed, the category of organic mental syndromes and disorders has been renamed as delirium dementia and amnestic and other cognitive disorders in the Diagnostic and Statistical Manual of Mental Disorders, DSM 4. American Psychiatric Association, 1994, so that the recognition of the role of abnormal brain functioning is not confined to dementia and delirium only. In their literal meaning, these categories of classification, i.e., organic versus functional, are absurd, yet they continue to be used through tradition, organic syndromes. The syndromes due to brain disorders can be classified into acute, subacute, and chronic. In acute organic syndromes, the most common feature is alteration of consciousness, which can be dreamlike, depressed, or restricted. This gives rise to 4 subtypes, i.e., delirium, subacute delirium, organic stupor or torpor, and the twilight state. Disorientation, incoherence of psychic life, and some degree of anterograde amnesia are features of all of these acute organic states. In delirium, there is a dreamlike change in consciousness, so that the patient may also be unable to distinguish between mental images and perceptions, leading to hallucinations and illusions. Usually there is severe anxiety and agitation. When stupor or torpor is established, the patient responds poorly or not at all to stimuli, and after recovery has no recollection of events during the episode. In subacute delirium, there is a general lowering of awareness and marked incoherence of psychic activity so that the patient is bewildered and perplexed. Isolated hallucinations, illusions, and delusions may occur, and the level of awareness varies but is lower at nighttime. The subacute delirious state can be regarded as a transitional state between delirium and organic stupor. In twilight states, consciousness is restricted, so that the mind is dominated by a small group of ideas, attitudes, and images. These patients may appear to be perplexed, but often their behavior is well ordered and they can carry out complex actions. Hallucinations are commonly present. In organic stupor, torpor, the level of consciousness is generally lowered and the patient responds poorly or not at all to stimuli. After recovery, the patient usually has amnesia for the events that occurred during the illness episode. In addition to the above, there are organic syndromes in which consciousness is not obviously disordered. For example, organic hallucinosis due to alcohol abuse, which is characterized by hallucinations, most commonly auditory, and occurring in clear consciousness, as distinct from the hallucinations of delirium tremens that occur in association with clouded consciousness. Amnestic disorders, of which Korsakoff's syndrome is but one, also belong in this group of organic disorders and are characterized primarily by the single symptom of memory impairment, in a setting of clear consciousness, and in the absence of other cognitive features of dementia. The chronic organic states include the various dementias, generalized and focal, as well as the amnestic disorders. Included among the generalized dementias are Lewy body disease, Alzheimer's disease, etc., while the best-known focal dementia is frontal lobe dementia, or syndrome. The latter is associated with a lack of drive, lack of foresight, inability to plan ahead, and an indifference to the feelings of others, although there is no disorientation. Some patients may also demonstrate a happy-go-lucky carelessness and a facetious humour, termed Witzelsucht, whereas others are rigid in their thinking and have difficulty moving from one topic to the next. The most common cause is trauma to the brain, such as occurs in road traffic accidents. The presence of frontal lobe damage may be assessed psychologically using the Wisconsin card sorting test or the Stroop test. Amnestic disorders are chronic organic disorders in which there is the single symptom of memory impairment. If other signs of cognitive impairment are present, such as disorientation or impaired attention, the diagnosis is dementia. The major neuroanatomical structures involved are the thalamus, hippocampus, mammillary bodies, and the amygdala. Amnesia is usually the result of bilateral damage, but some cases can occur with unilateral damage, and the left hemisphere appears to be more critical than the right in its genesis. Classification. Functional syndromes. Functional disorders, a phrase seldom used nowadays, refers to those syndromes in which there is no readily apparent coarse brain disease, although increasingly it is recognized that some finer variety of brain disease may exist, often at a cellular level. For many years it was customary to divide these functional mental illnesses into neuroses and psychoses. The person with neurosis was believed to have insight into his illness, with only part of his personality involved in the disorder, and to have intact reality testing. The individual with psychosis, on the other hand, was believed to lack insight, had the whole of his personality distorted by the illness, and constructed a false environment out of his distorted subjective experience. However, such differences are an oversimplification, since many individuals with neurotic conditions have no insight, and far from accepting their illness, may minimize or deny it totally, while people with schizophrenia may seek help willingly during or before episodes of relapse.